Hi, I'm Matt Collins, and today I'm going to be performing Quick Track 2. Firstly, I need to put the patient in the best position, and what I need to do is hyperextend the neck. What this does is it makes it easier for me to find the anatomical landmarks for locating the cricothyroid membrane. Patient as best they can with the BVM and end titles. To test the Quick Track, I need to inflate the cuff to make sure that the cuff inflates, and then I can get a good seal. I'm blowing it up, and I can tell from this that it's good. Prior to RSI and prior to getting to cricothyroidotomy, it's essential that when you're assessing the airway that you assess the neck, and you can palpate the trachea and palpate the neck to examine the patient's anatomy and see if there's any abnormalities or any trouble that you might come across if you do get to failed intubation drill. Once I've got the patient's head hyperextended, I'm able to find the landmarks easier. I've got here my thyroid cartilage, and just below this I can feel my cricoid cartilage just below it. What I do is I swab the area, and once I've located it, I make a horizontal line just like so for my cricothyroid membrane. A cricothyroidotomy is indicated in the instance where a can't intubate, can't oxygenate scenario arises, or it may be utilised during your primary survey at the airway assessment, for example in an anaphylactic patient. I've got my cricothyroid membrane marked out. I grab the skin, pinch it like this to stabilise it. I grab my Quick Track like so, and I advance my needle at 90 degrees to the skin and punch it through until I get to the red stopper. Once I'm there, I can angle 60 degrees. I grab my 10mm syringe, my 5mm syringe, and I aspirate air to ensure that I'm in the trachea. Once I know I'm there, I remove my red stopper, and whilst at 6 degrees, I advance the Quick Track, and then withdraw my cannula, putting it in the sharps container. Blow up my cuff with the 10mm. Grab my BVM on the end, attach like so, and ventilate the patient. Once I've placed my cricothyroidotomy in with using the Quick Track, and I've attached my end tidal to my monitor and ensuring position with end tidal capno, I can secure the device like so up here, up underneath the patient's head, fold it back down, and then like so on the other side. And then from here I ventilate the patient at whatever is necessary for the patient's condition, 6 to 7 mils per kilo, 8 to 12 ventilations per minute. Other ways to confirm position of the Quick Track is also chest auscultation, and then also ensuring that your SpO2 is at normal levels. With post-procedural care, there are some considerations that need to be taken. These include sedation and paralysis. If you've had to perform cricothyroidotomy, there has been a difficult or problem with the airway resulting in a failed intubation. Once it is secure, you want to do everything so that it doesn't dislodge. Sedate the patient to make sure they don't pull it out, for example. Paralysing the patient could be fraught with danger and the chance that the quick track dislodges. Then there is no secure airway, which you have just had to perform a cric on, as it was difficult to get an airway. I will be holding onto this quick track from the moment that it's in to when you get to hospital, and I will be sedating them and most probably using some ketamine to keep the patient in a dissociative state so that you can maintain the quick track. One of the pressure points associated with quick track can be the actual insertion of the device. Sometimes it can be difficult to insert through the skin and through the actual membrane. So what can be utilised is through a scalpel is a vertical incision, essentially creating a cut down of the skin to gain access to the cricothyroid membrane. And then if it's still difficult to puncture through that with your quick track, you can do a horizontal incision through the membrane to advance the quick track into place. Just mindful of the blood as well, there might be a bit of blood. Another surgical technique utilised by ambulance services is the use of a bougie and a endotracheal tube. What's done is with a scalpel is a vertical incision along the midline, along the anterior aspect of the trachea, feeling just below the thyroid cartilage and over the cricothyroid membrane. So the vertical incision is made first, and then a vertical incision along the cricothyroid membrane, and then a bougie is feeded down into the trachea, and then a size 6 ET tube is railroaded over the top and secured in place. The Cook-Melker device is another device utilised for cricothyroidotomy airways. It's a wire-guided cricothyroidotomy airway, and it's manufactured in a variety of cuffed and uncuffed sizes. It is inserted using the Slendinger technique, which is very similar to the insertion of a central venous catheter. The cuffed version comes as a 5mm ID cuffed PVC airway with pre-inserted curved dilator, a flexible tip guide wire, an 18-gauge cannula over needle, and an 18-gauge introducer needle, syringe and scalpel. It is possible to establish ventilation through a cuffed Melker device in mannequins in around 40 seconds. The Portex cricothyroidotomy is another kit utilised for surgical cricothyroidotomy in different ambulance services. It is a rigid cannula over needle device packaged as a pre-assembled set with scalpel and a 10mm syringe. A syringe-loaded Verus needle with blunt stylet is nestled in an integral dilator over which a 6mm ID cuffed airway fits. There is a small red flag indicator in the needle hub which disappears with loss of tissue contact, indicating intratracheal placement. One mannequin study has shown insertion time to be around 30 seconds.